Everybody. To those of you arriving just now, welcome to today's virtual roundtable. I think this is the 12th installment of our series. It's hard to believe how quickly time goes. It's already the second year. But welcome. Let's begin. Today, we are joined by our team, our BOLD public health team in Colorado, and we'll be hearing about their work. My name is Elma. I am the coordinator of the BOLD Public Health Center of Excellence on Dementia Caregiving, and I also work here at the University of Minnesota's Center for Healthy Aging Innovation on our public engagement and community efforts. Next slide. We want to always start by acknowledging that our university is located on the ancestral homelands of the Dakota people who have stewarded this land for generations. And we believe it's important to acknowledge the people in whose land we live, learn, and work, whether it's in a virtual or physical space. And we seek to improve and strengthen our relationship with our tribal nations. We know that words are not enough, and our university is committed to providing support, resources, and programs that increase access to all aspects of higher education for our American Indian students, staff, faculty, and community members. I also want to add that for those of you who might be joining us today from Florida, thank you for being here, and we hope that you, your family, all of yours are well and safe today. Some of those images from the hurricane last night and this morning were scary and disheartening. Thank you for being here. Next slide. Many of you probably, this is not your first time that you're joining one of our sessions, but a very brief introduction. Our center's goal is to really build public health capacity nationwide to develop the support infrastructure for our family caregivers of people with dementia. We do that in several ways by improving access to evidence-based programs and best practices to support caregivers, by facilitating connections between public health departments, programs, and a variety of other agencies and organizations providing support for families affected by dementia, and also by providing technical assistance and tailored support to public health agencies at the state, local, and tribal level. You can learn more about us on our website, and feel free to engage with us in the same message or an email anytime. Next slide. Our center is part of a national collaborative, the Healthy Brain Initiative Collaborative, which is a group of national partners working together to integrate fully cognitive health, dementia into public health practice, and elevate it as a priority for public health. Together, we work to improve brain health for all of us, and especially for underserved populations. These are the members of our collaborative group of subject matter experts. Please, I encourage you to visit our websites and learn more about each of the member organizations. Next slide, please. This is we have envisioned. We've designed this as a meeting, as a really interactive space. This is a bi-monthly roundtable series in which we hope to create a community of practice, and we highlight one story at a time, one state. Today, we welcome our BOLD team in Colorado. And this is a space for networking, for hearing from one another and asking questions and sharing our work that we believe can inform others' work. So do not hesitate, please, to raise a question. Q&A is available at the bottom of your Zoom monitor. Please submit questions and ideas to our speakers. Next slide, please. Just a few reminders, housekeeping reminders, because this is a Zoom meeting. Please mute yourself, but feel free to turn your video on while the panelists are presenting to really give that feeling of space, of shared space. Add your name and your organization in Zoom so we know where you're joining us from. Again, use the Q&A for questions, and use the chat to share any other resources or materials you think are relevant to today's topic and to Colorado's work. And we will have time at the end for your questions. And please let us know, of course, how we did today. We really take your feedback seriously to improve all of our future programming. So I think with that, you can scan this code. You can have it open in your phone to tell us how you like today's event. Before we begin, my colleague Ashley is going to launch a poll very quickly to see who all is in the room today. Please respond in what capacity you're attending today's event. We just want to know who is here with us. I am going to share the results in just a second as everybody has had a chance to answer. Great to see our bold public health programs. Over a third are bold public health agencies here today, followed by community organizations. Let me see. I am going to end the poll right now and share with you. You should be able to see it now on your screen. Bold public health agencies, 25%, and another quarter community-based organizations and service providers. Welcome, everybody. Of course, we have a few caregivers and care clinical professionals in addition to that. And without further ado, I welcome Monica and Joanna from our Colorado Bold team, who will be sharing about their successes, lessons learned, and what Colorado has been up to build that infrastructure for people with dementia, families, and caregivers. Thank you both for being here today.
Thank you for having us. Well, hello, everyone. Thank you for joining us for today's presentation as we highlight features from the Colorado ADRD State Plan and the Colorado Alzheimer's Disease and Related Dementias Action Coalition. Before we get started, I did want to define a few acronyms. So the first one is ADRD, which stands for Alzheimer's Disease and Related Dementias. And then the next is ADRDAC, which stands for Alzheimer's Disease and Related Dementias Action Coalition. And then the third is CDPHE, which stands for Colorado Department of Public Health and Environment, which is where our BOLD grant sits. Next slide, please. So for today's presentation, we will be starting out with providing an overview of the Colorado ADRD State Plan that will include some statistics that drove the development of our state plan. And then we'll be providing an overview of our Action Coalition as well as our work groups, highlighting projects and successes of each of our work groups. And then we will discuss how the Action Coalition has integrated care partners and caregiving into our state plan activities, and then move into discussing our ADRD data source matrix, how we've utilized data to implement our state plan with our Action Coalition, and then close out the presentation with discussing some successes and challenges. Next slide, please. So first up, we are going to share some Colorado statistics related to ADRD and older adults. Next slide, please. So to set the stage for the rest of the presentation, it is helpful to share some statistics around older adult population here in Colorado. So age is the #1 risk factor for dementia, and Colorado has one of the fastest growing populations in the nation and is rapidly becoming more racially and ethnically diverse. From 2010 to 2019, Colorado has had the 6th highest rate of population growth in the nation and the 3rd highest rate of population growth among older adults. An estimated 922,000 Coloradans are 65 years or older, and according to the Colorado State Demography, that by 2050, 1 in 5 Coloradans will be over the age of 65. Of those, over 90,000 older adults are living with ADRD, and we are expected to see a 21% increase in people living with ADRD between 2020 and 2025. ADRD is a growing concern in our state, as Alzheimer's disease is the 7th leading cause of death in adults in Colorado, and Alzheimer's disease has climbed to be in the top 5 leading causes of death among Coloradans who are 75 years or older. Next slide, please. And similar to other chronic conditions, ADRD disproportionately impacts communities of color. Nationally, people of color currently make up about 20% of the population aged 65 years or older. By 2050, people of color will make up nearly 42% of the population, and these changes are projected to be similar here in Colorado. Compared to their white counterparts, Latino Hispanics are 1.5 times more likely to develop ADRD, and Black African Americans are 2 times more likely to develop ADRD. We also know that the number of American Indian, Alaska Native older adults with dementia is projected to grow over 5 times by 2060. These 3 populations, which we call our priority populations, are also less likely to receive a diagnosis and have limited access to care, resources, supports, and services. Due to the lack of early diagnosis, these communities are also less likely to be represented in research. Racial and ethnic differences in current rates of dementia suggest that there will be a 7-fold increase in Alzheimer's disease cases among Latino Hispanic adults, a 5-fold increase among American Indian Alaska Native adults, and a 4-fold increase among Black African American adults by 2060. Additionally, Colorado has one of the largest Latino Hispanic populations in the country at about 23%, and the Colorado State Demographer's Office predicts a 125% increase in the proportion of Latino, Hispanic, Chicano adults over the age of 65 by 2050. Additionally, in developing the activities that can be found in our Colorado ADRD state plan, we have intentionally included activities that have a focus on our priority populations, and each of the activities within the state plan has a health equity lens to ensure our priority populations are included in the conversation. Next slide, please. The last statistic that we wanted to discuss before moving into the development and implementation of our Colorado ADRD state plan is the financial implications and impact on our state. The financial burden of caring for people with ADRD is significant, and in 2020 alone, it cost Colorado Medicaid $635 million to care for individuals with Alzheimer's disease, and by 2025, these costs are projected to increase by 24%. On average, Medicare spending for a person living with ADRD is more than 3 times the average Medicare spending for a beneficiary without dementia. And this puts considerable burden on the individual, the families, health systems, and the state as a whole. However, it is important to note that there are proven strategies to help reduce these costs, including early detection, appropriate care interventions, and support for care partners to help mitigate the financial strain and improve impacts of people living with ADRD. One of the early signs that often precedes a formal ADRD diagnosis is impaired financial decision-making. And many individuals with experiencing early dementia experience difficulties managing their finances, missed bill payments, and vulnerability to scams. And sadly, fraud targeting older adults is a growing concern. And in 2021, adults over 60 in Colorado lost more than $33 million to internet fraud, representing over 3,500 victims, ranking our state as 8th highest in the nation for losses of this kind. And cognitive decline makes these individuals more susceptible to these schemes, further compounding the strain on families and people living with dementia. And now I'll pass it to Joanna to discuss our Colorado ADRD state plan. Next slide, please.
Thank you, Monica. All right, I'm going to dive into the development and implementation of our Colorado Alzheimer's disease and related dementia state plan. And if you're interested in looking through the plan, we will add the link to the chat. Thank you. Great. So as Monica mentioned, we recognized ADRD as a growing concern in our state and its desperate impact on communities of color, our rural communities, and care partners. So in response, CDPHE pursued and received funding from the CDC through the Building Our Largest Dementia Infrastructure, or BOLD initiative grant. We convened a diverse group of stakeholders in 2021 that formed what was then the ADRD Advisory Committee. We informed the development of the ADRD state plan through a strategic planning process, including several data collection analysis methods in combination with guidance that we got from the CDC's Healthy Brain Initiative roadmap. The findings from our research were distilled to the advisory committee, and combined with their expertise and knowledge, they prioritized actions from the Healthy Brain Initiative roadmap and then developed activities for implementation in Colorado. Our state plan here finally became available in the summer of 2022. We received a second award from BOLD last year to fund the 5-year implementation of the state plan. And just this last week, we concluded year 1 of implementing the Colorado ADRD state plan. The ADRD Advisory Committee is now the ADRD Action Coalition, or ADRAC, as we call it. And we're looking forward to continuing implementation of the activities outlined in our plan to help Colorado develop a strong public health infrastructure to address ADRD, with the focuses on risk reduction, early diagnosis, prevention and management of comorbidities and avoidable hospitalizations, and supports of Coloradans living with or caring for a loved one with ADRD. We also want to highlight that the Colorado ADRD state plan has an intentional focus on priority populations. Monica named some of these populations of higher burden for developing ADRD and lower rates of diagnosis and limited access to care. These priority populations include the American Indian, Alaska Native community, Black and African American community, Latino, Latina, Hispanic, Chicano, Chicana communities, as well as we recently added rural communities and care partners as priority populations as well. And then lastly, we want to underscore the dedicated and passionate members of our ADRAC who are leading the implementation of the state plan alongside with us. We have representation from across the state, including in urban and rural communities, frontier communities, and we also have care partners who sit in our ADRAC and other priority population representatives. We have researchers, advocates, academics, healthcare providers, state and local public health staff, adult protective services, and long-term care staff, just to name a few. So we have a very diverse and dedicated coalition that have been key to making progress in our plan. Next slide, please. The Colorado ADRD state plan incorporates a public health perspective to address upstream factors that may be modified, as well as the systems and environments that can impact ADRD risk factors. The actions that were selected for the ADRD state plan were identified based on the 2018 to 2023 Healthy Brain Initiative Roadmap. The roadmap outlines 35 effective public health actions to address ADRD, utilizing research conducted by CDPHE and combined with the expertise. Our ADRD Advisory Committee prioritized 12 of those 35 roadmap actions to be included in our state plan. After prioritizing the actions, the ADRAC developed 55 activities in total that outlined how Colorado would achieve the actions in the state plan. The 55 activities within the plan are divided among the 4 different domains that you see on the slide here. And our action coalition, so the advisory committee transitioned into an action coalition, is made up of 4 different work groups that are working on the activities within the 4 domains of the plan. In the next section of this presentation, we're going to dive deeper into each of the work groups and provide some insight on some of the projects and progress that we have made so far. I'll focus on the coming slides on some of the initiatives that include care partners in our plan. Next slide, please. So the first of our 4 work groups is the E work group, which stands for Empower and Engage. The activities within this work group are focused on educating the general public, including tailoring for our priority populations. One of the big projects of this work group is focused on the development of a public awareness campaign. The first phase of this campaign focused on reducing stigma, raising awareness of ADRD, warning signs and risk factors, and starting the conversation about dementia with loved ones and providers. We'll be adding a link in the chat for those interested in exploring our website, which was part of this campaign. It does include a section on care partners and also ways to get involved. And this initiative has led to us getting connected with several care partners that have wanted to partner with us, either by sharing their stories or participating within our ADRD Action Coalition. Next, this work group is focused on promoting education to multiple audiences, including those living with ADRD and their care partners within urban and rural communities. The group has developed an initiative called the Community Education Partners, or CEP, which is an opportunity for organizations and other partners to participate in promoting and expanding education and increasing access to education related to ADRD. The CEP initiative includes a series of courses that support care partners through their journey. And this initiative is led by an ADRDAC member from the Alzheimer's Association and one from Dementia Friendly Denver. They've created really great connections across the state, most notably with our libraries. And then lastly, we have partnered with Mile High United Way 211 to create an ADRD and care partner resource repository. This partnership allows for resources, services, and supports for people diagnosed with ADRD and their care partners to live within the 211 system, which already includes a robust listing of social services. Our partnership with 211 also allows for them to keep the ADRD resources that we add up to date on an annual basis. And the landing page, which Monica has shared with you in the chat, is now live, provides a much needed resource to share with the public and with healthcare systems and providers, as there has been a need for a centralized repository for ADRD resources to send folks and their care partners to after diagnosis. So we hope that you are able to explore that website. If you are familiar with Colorado ADRD and care partner resources and see any that are not listed in the repository, please let us know, as we're able to get those added and make sure that they remain up to date in the repository. And then lastly, over the summer, the eWork group disseminated an ADRD rural survey to gather information on current efforts, needs, barriers, and resources regarding ADRD programs and initiatives in rural areas of Colorado. The responses have been analyzed and distilled to the ADRDAC, and they will help inform the work of the ADRDAC in identifying, understanding, and promoting ADRD best practices in rural communities and supporting the implementation of the Colorado ADRD state plan, including activities that focus on care partners. Next slide, please. The P work group, or our Develop Policies and Mobilize Partnerships work group, focuses on promoting best practices and evidence-based interventions, developing partnerships, and informing policies that support people living with ADRD and their care partners. Developing healthcare professional recruitment efforts that target priority populations is a policy recommendation that we identified in previous research. And not only does this help address the need for a larger workforce to care for our people living with ADRD and their care partners, but it addresses the fact that our aging population is getting more diverse and will have unique needs that need to be addressed with cultural sensitivity. This past February, the P work group attended the Colorado chapter of the Health Occupation Students of America, or HOSA, state conference, which is a student-led healthcare-focused organization. And the group presented 2 symposiums on ADRD and the state plan and tabled at their conference, and also engaged students through completing what we called the BIPOC, or Black, Indigenous, People of Color Healthcare Workforce Questionnaire, to learn about what they seek and their needs for support and services when pursuing a career in healthcare. Additionally, we have developed a working partnership with the Colorado Community College education system to learn more about existing initiatives, or incentives, and opportunities for the BIPOC community in pursuing careers in healthcare, and the integration of ADRD education into existing courses or education tracks. We're also seeking to continue our involvement with HOSA and to start working with the University of Colorado, Colorado Springs, and their program called Jumpstart the Aging Workforce Solutions, or JAWS. This is a program that incentivizes high school and college-age students to pursue careers in long-term care and related fields to support older adults. The group has presented, this work group has presented the state plan at the Alzheimer's Association Day at the Capitol, and a policy briefing to Colorado legislators and policymakers to provide education about ADRD, the impact of ADRD on Colorado and care partners, and an overview of the ADRD state plan. We plan to continue these educational presentations to policymakers so that they can make informed decisions when policies come across their desks that support the lives of people living with ADRD and their care partners. And we also know that mental health is a concern and a need, both for people living with ADRD and their care partners. And the P work group has successfully initiated communication with community mental health centers and local behavioral health centers to learn more about the services and protocols that exist for people living with ADRD and their care partners. We're exploring options focused on policy initiatives to improve the care coordination and community clinical linkages for folks diagnosed with dementia. Next slide, please. Our third work group is the W work group, or Assure a Competent Workforce. And they're focused on training professionals who offer services for people living with ADRD, including public health, healthcare providers, first responders, and long-term care, just to name a few. There are a few call outs for the W work group. The first is the e-learning module for primary care that we developed in partnership with the University of Colorado's Practice Innovation Program. And thank you, Monica has added this to the chat. Primary care professionals play a pivotal role in diagnosing Alzheimer's disease and related dementias and recommending lifestyle changes that can help their patients reduce the risk for dementia. They are also able to identify care partners and better tailor their care, understanding their unique needs and challenges. This informational interactive e-learning module is designed for primary care teams to increase their knowledge and skills related to ADRD. The module discusses risk factors for ADRD, risk reduction strategies, evidence-based practices for culturally sensitive ADRD care, identifying a care partner, and using a team approach to ADRD care. The primary audience is primary care providers and their staff members, but it is free for all learners. And individuals who are eligible and complete the training can receive 2 AAFP CME credits at no cost. And additionally, the e-learning module includes education on the annual wellness visit, cognitive assessments, and care planning. We will continue renewing the CMEs for this year to year, and we'll continue making any updates as needed to the modules. So the link and registration code that Monica has shared in the chat is for any who are interested to access the module or share it among any primary care staff in your areas. Next up on our list of projects is a training module for public health professionals. We're currently working with the Rocky Mountain Public Health Training Center to develop an ADRD training module with the intended audience of public health professionals and students. The goal of this project is to train and educate public health professionals about ADRD and care partners and provide context on how it connects to their role as public health professionals and what they can do to address ADRD through their work, such as messaging, education, inclusion in state plans, and others. The project just kicked off this month, and the modules will be completed next year, but they will be available free of cost to anyone in the Rocky Mountain region. And lastly, we're working to integrate brain health messaging into existing messaging avenues for healthcare providers that specifically underscore the importance of engaging care partners and the impact of ADRD on care partners. And that's work that we're kicking off this year. Next slide, please. Last, but certainly not least, is our M work group, or Monitor and Evaluate, which focuses on using state and local data to improve decision-making. The M work group is focused on maintaining a list of surveillance systems and data sources for ADRD indicators, and the group created a data matrix to host these data sources, which is available for internal use of the ADRDAC. We'll talk about this a little bit later on in the presentation. The second task is to convene a data subcommittee, which we are in the process of creating with the help of our Priority Population Coalition champions. These are folks in our coalition who have volunteered to be the point of contact between our ADRD Action Coalition and priority population organizations. The M work group is continuously reviewing any available qualitative and quantitative data to inform implementation and evaluation of the state plan. During the prioritization process of the actions outlined in the Healthy Brain Initiative Roadmap, our ADRDAC decided to only include the required action M3 into the Colorado ADRD plan, and we developed 4 activities within this action. So While small, this work group has done a lot of great work to support the efforts of other work groups. I'll be highlighting some of the projects and successes in the M work group a little bit later in the presentation when we talk about the data source matrix and use of data by our coalition to implement the state plan. I'll pass it back over to Monica.
Okay, so now that we have given an overview of the Colorado ADRD state plan and the Action Coalition, I'm now going to provide an overview of how we've integrated care partners and care planning into our activities across the 4 work groups. So to start out, like Joanna had previously mentioned, we have added care partners to our list of priority populations because we recognize that they have unique needs in maintaining their physical and mental health that need to be addressed intentionally in order for them to be able to provide care for themselves and loved ones living with dementia. And so on the next slide, please, I'll dive into some statistics. In the Colorado ADRD state plan, we use the term care partners, and we define care partners as informal, unpaid caregivers, usually friends or family members, who provide care and support to a loved one living with ADRD. And they play a huge role in supporting folks living with ADRD, and it is important to remember that they need support too. So we wanted to take some time to review some Colorado-specific statistics to give scope to the work that we are doing here in our state. So providing care for those living with dementia takes up a lot of time and resources. And in 2022, approximately 177,000 care partners in Colorado provided 307 million hours of unpaid care to individuals with dementia. This was estimated to be more than $7 billion in unpaid care provided by care partners in Colorado. And according to the 2024 Colorado Alzheimer's Facts and Figures from the Alzheimer's Association, 58% of care partners report having chronic conditions, and about 37% report having depression. We also know that 1 in 3 care partners for people living with ADRD report that their health has worsened since providing care for their loved ones with dementia. And this is compared to 1 in 5 care partners of older adults without dementia who have seen a decline in their health. Next slide, please. We are fortunate enough to have care partners with lived experience in all 4 of our work groups, including care partners who have a dual role as a care partner and a professional, those with lived experience as a care partner for loved ones with a variety of ADRD, and care partners from rural and urban communities. Through their involvement, care partners have shared their expertise and journeys, and they have aided in the ADRDAC's ability to continue our efforts towards addressing equity and ensuring that we are in alignment with the HBI roadmap and BOLD grant as we implement our state plan. I'm now going to walk through each of our work groups and highlight a few activities that we have integrated care partners directly into. So for the E work group, we have 4 activities. The first one is the E1.1, which is the activity that's focused on our public awareness campaign that Joanna spoke to earlier. So through the launch of this public awareness campaign, we have directed folks to access our website, talkaboutdementia.com, where they have access to services, supports, and resources, as well as the option to sign up for our quarterly newsletter and indicate their interest in learning more and or joining the ADRDAC. If they express interest, we follow up with them to learn more about their experience, interest, and expertise. And through this pathway, we have been able to connect with a number of care partners who have requested to stay connected or join our coalition, further diversifying the voices and experience and expertise of our coalition. For E1.2, which is focused on education, the Community Education Partners Initiative, the E-Work Group has been offering the empowered caregiver education through the Alzheimer's Association to organizations in addition to the general dementia education. And then with E1.5 and also looping in W2.2, we have been working in collaboration with a number of care partner organizations to develop print materials focused on risk reduction, warning signs, supports and services, and affirmations that will be included in care packages that are being sent to care partners during National Caregivers Month in November. And then lastly, for the E-work group, E7.1, and also looping in P5.3, these two activities are focused on identifying care partners to include in the online repository with Mile High United Way 211, which we shared that resource earlier in our presentation. For the P-work group, we have integrated care partners into the verbiage of these activities to ensure that we are, one, including them in the conversation, and then two, also identifying best practices and evidence-based interventions to best support our care partners. Two primary callouts for this work group is P1.4, which is an activity focused on policy initiatives and advocacy work. And we recently started exploring the opportunity to start a project to implement dementia care specialists into our state. And so if your state or organization has implemented dementia care specialists in your state or in the process of exploring it, it'd be great for us to be able to connect with you to learn more about the process. The other activity is P1.5, which is focused on behavioral health. And during the first year of our grant, like Joanna mentioned, our P work group members connected with behavioral health providers to learn more about how folks living with dementia move through the behavioral health system. And they learned that through this work that providers recommend focusing on care partner mental health and ensuring that their behavioral health support is met. So we have shifted the scope of this activity for year 2, and we will be focusing on care partner mental health. And additionally, we are working to collect care partner stories to help with our advocacy efforts in educating policymakers. For our W activities, these are focused on educating providers on care planning, identifying care partners, and including the care partner in conversations during the detection and diagnosis phases. We have developed and launched an e-learning module, which we shared that in the chat as well. And it is intended for primary care providers and their staff members to educate them on these care partner and care planning topics. And lastly, the M work group. All 4 activities for this work group include care partners, and we will speak directly about the work that they are doing for this work group in the next section of our presentation. The next slide, please. And before we move into talking about data for our presentation, we did want to ask the following question that is listed here on the slide. And it is, what have you and your organization done to engage care partners in the work that you are doing? And feel free to share your answer in the chat, and we will just take some notes on that. But you are welcome to do that now, and then I will pass it over to Joanna to talk about data.
Thanks, Monica. We'll give folks just a minute to look at this question and see if there are any answers that come through before we move on.
Joanna, may I ask a question while participants are maybe entering their responses? It's actually not, it's just a follow-up on your W work, developing capable workforce slide earlier. You mentioned you're working to develop a curriculum for public health students and professionals. The Alzheimer's Association actually developed 3 curriculums that you probably are using, or at least they can help shape some of this work or inform some of that.
Yeah, Monica was actually part, and I was part of it in the beginning too, reviewing the modules before they were published. We're hoping that the information that we have in the Rocky Mountain Public Health Training Center dives deeper than those modules did and includes Colorado specific information. Yeah, but you're right. For other folks who don't know, the Alzheimer's Association, through their, as a public health center of excellence on dementia risk reduction, have developed some great modules that are available. All right, we can move on to the next slide. We're going to talk about data, and one more slide, please. All right, so like we previously mentioned, our M work group has 4 activities that we're working on. One of the primary projects is to help progress the activities. One of the primary projects that is helping progress our activities was the development of the data source matrix. The M work group developed the data source matrix to be used as a tool by other members within our coalition. within our other 3 work groups that can help identify data sources they could utilize to help drive the implementation of their activities. The matrix organizes and maps out primary and secondary data sources focused on ADRD, care partner, and older adult data that were relevant to the implementation of the ADRD state plan. And the matrix has also helped us see what data is available, but also what gaps in the data are here in Colorado related to these topics of interest. To develop the data source matrix, the M work group put a list together of all data sources that were known that represented ADRD or caregiving in Colorado, and we identified data owners within a spreadsheet. We then provided this to the ADRDAC members and asked them to add any data sources that they had previously used, or if appropriate, to identify themselves as an organization who has data available to share. After the list was finalized, the M work group developed a key informant interview guide and split up the data sources within members of the work group. Each of us connected with several data sources or data source owners and used the KII guide to learn more about the data that they owned, including the type of data that was included and the process and cost for requesting data. To streamline our approach, the group also developed an email template for that initial contact to the data owners. Once complete, the M work group presented the data resource or this resource to the ADRDAC during our quarterly meeting, and it is now live and it's available for internal use. Currently, it's being utilized by the work groups as a reference to see what data is available for them to utilize to inform implementation of their work. We'll post the current version of the data source matrix in the chat for you all to take a look at, and you're welcome to use this as a template for replication for your organization. Next slide, please. We wanted to also walk through some of the information that was included in the data source matrix. So on the screen here is a list of items that were included in our matrix. First, we have the source type, including if it's primary or secondary data source, and if it is Colorado specific or site specific. Data source, so if this is an ADRD data source or care partner or just general older adult data. The population that is represented, who the data owner is, a primary contact and their role at the organization, a secondary contact if it's available. Also accessibility. So is there a cost to access the data, or is a data use agreement needed in order to receive it? Topics that are covered by the data source, any specific questions answered by the data source, any other notes, and then lastly, resource location, such as their website or internal system. So all of this information, when available, we gathered through our key informant interviews to complete our matrix. Next slide, please. And here's an overview of the data sources that we have utilized since the data source matrix has been launched for internal use. We used Colorado local, county, and state level data, behavioral risk factor surveillance system, or BRFSS data, specifically the cognitive decline and care partner optional modules, which we support and include in alternating years. The all payers claims database and CPT code data from CIVIC, or the Center for Improved Value in Healthcare. And we're expecting data from Bell Policy and Colorado Respite Coalition. They just wrapped up a caregiver mental health survey, and this includes dementia-specific questions that were added as part of the work of our coalition. We're also exploring options for how to utilize data from the Colorado Managed Care Network, which focuses on rural hospitalization data and federally qualified health systems. Next slide, please. All right, and before we pass it over to Monica, we have another question for you. Does your organization, coalition, or committee have access to data sources that collect data on different types of dementia? So I think we'll pause for a second to give folks a chance to answer, but you can keep typing in answers as Monica moves on too.
Okay, next slide, please. So to provide a little bit more context to the way our work groups utilize data, the eWork group has utilized county level data and local level data for prioritization of outreach for our public awareness campaign, community education partners initiative, and the rural ADRD survey dissemination. The outreach efforts for the CEP's initiative and the rural survey dissemination utilized the priorities listed in community health assessments for each of the Colorado counties and regions. And this information was combined with the county and local level data, specifically data related to older adult age 65 years or older, adults with chronic conditions, and a few other metrics that led to the prioritization for outreach. Additionally, this group has utilized BRFSS data for presentation development and message integration for chronic conditions. Next slide, please. The PWork group has reviewed the data source matrix and recognized that there was an overall lack of care partner data that was available, and the data that was available was secondary data, and so not that primary data. The lack of care partner data led to the involvement in the development of the caregiver mental health survey that Joanna spoke to, that was in partnership with the Bell Policy and the Colorado Respite Coalition. And I want to give a shout out to our champions for this activity, Amy and Coral, who were advocating for dementia-specific questions to be included on this survey. So we will get some great care partner data related to dementia care partners once that data is analyzed. The group also uses state-level data and care partner data, including sources from the Alzheimer's Association, to develop policy briefings to educate policymakers and legislators. And this data has also been included in presentations for a wide variety of audiences, including for students and public health professionals, and for our presentation for today. Next slide, please. The W work group will be utilizing all payers' claims data from the Center for Improving Value in Healthcare. Our chronic disease epidemiologist, Hannah, is in the process of analyzing the data we received through a data use agreement, and the data includes CPT codes for care planning and cognitive assessments. And this data will be utilized for a number of activities to help with focusing our provider education and also allow us to prioritize outreach to specific areas in the state, both in areas that have high rates of use of CPT codes and those with low rates of CPT codes, so we can learn a little bit more about why or why not providers are using those CPT codes. Next slide, please. And since the launch of the data source matrix, the M work group has continued to improve the accessibility and data for the work groups through developing a data request form, introducing data walks, aiding in data analysis, developing a Smarty Goals tracker, and creating a group called our Air Traffic Controllers, which consists of our priority population champions that have helped work groups with outreach, tailoring resources based off of their expertise. Next slide, please. And we have one more question for you. It is, how has your organization utilized data? And you can feel free to add your answers in the chat. And then I will pass it over to Joanna to talk about our successes and challenges.
All right, so before wrapping up our presentation, we wanted to discuss some successes and challenges we faced with data. Next slide, thank you. On the left side are successes here, which include that this is one of the first repositories of quantitative and qualitative data for older adults and aging. Collaboration across the AdderDAC and crowdsourced nature ensured that we had a comprehensive list. And the list has been helpful in identifying where data gaps may exist and prioritizing efforts for our state plan implementation. On the right, we see some challenges, and these include finding information for each of the data sources that were provided by AdderDAC members. Data use agreements and privacy requirements can be a challenge. Identifying a contact for each data source sometimes has been challenging, as we may only have a maybe web page or general inbox listed. There's limited data around experiences of older adults, limited data sources for non-white populations, including priority populations, lack of data sources on other types of dementia other than Alzheimer's disease. And it takes time to analyze data. We're fortunate to have a chronic disease epidemiologist, who Monica mentioned, Hannah, who co-chairs our M work group and can help analyze data that is received in response to data requests that come in from our the rest of our coalition. But we know that not every bold grantee or state agency has this. Next slide. And then lastly, a few callouts for successes and challenges that we faced broadly in implementation of the Colorado ADRD state plan. Some successes include retention of our ADRDAC members. We have a really passionate group of coalition members who are dedicated to implementing the state plan. Continuous recruitment of new members. We're often onboarding new members to participate in the coalition, and engagement of care partners in the ADRD coalition. As Monica, as we mentioned earlier in the presentation, our public awareness campaign has increased visibility of our work, and we've had a lot of care partners reach out for us, which has been great being able to incorporate them into our work. We've had many presentations, education and training opportunities, including conferences and tabling events, and we are making progress year to year in this work, which is exciting. A couple of the major challenges include the capacity of our priority population representatives, and then just broadly organizations that work with priority populations are stretched very thin. And so it is hard to get them to have dedicated efforts as part of our work. And then due to the nature of the reality of dementia disease progression and care partners, their capacity is also limited. And so getting care partners fully engaged in the level of work that it takes to be a partner in implementing the state plan can sometimes be challenging. Next slide, please. So a question that we have for you, and you can answer as we move on, is what definition do you use to define an equity lens when thinking about it from a data perspective? Something that's come up in our conversations before. And let's move on, and so we can leave some time for questions. So just some resources to leave with you here. On the screen is a QR code that you're welcome to scan if you're interested in signing up for a quarterly newsletter, especially if you live in Colorado. The next one will be sent out now, I think in October, and it's a great avenue for learning about the work of the Colorado ADRD Action Coalition. We also share educational and training opportunities or volunteer and funding opportunities there and other related information. And then Monica can link the form in the chat for you as well if you don't want to scan the QR. And next slide. And then to close out our presentation, we wanted to give a big thank you to our M work group, including Danelle, Hannah, Rachel, Amy, Meredith, and Lisa, and the other members of our ADRDAC. Next slide. And that is all we have for you today. So our contact information are on these slides here. But I think we have a few minutes for questions that you may have for us. Thanks, and Monica's putting in our emails in the chat as well.
Oh, this was just great. Thank you, Monica and Joanna, for taking the time to prepare and really share about your work. It's really impressive, all the engagement you've done through your ADRDAC, if I say that correctly.
We love acronyms in Colorado.
Yeah, we do too here. Great work. Congratulations. So I do have one question. I have actually more than one, but I'll let our audience first ask theirs. If anybody has a question, feel free to maybe unmute yourself. We have 5 minutes left. Any questions related directly to the work that you heard about today? Or anything you would like to share about your work that you think Monica and Joanna and their team would welcome, or related to one of those questions they asked from you all. There's a question, Monica and Joanna, in the chat. How is the upcoming implementation of community first choice in Colorado benefiting ADRD state plan or your work group?
I don't think we've had conversations about that. Have you, Monica? And
No, I'm looking at it now, and it looks like it's an optional Medicaid program that allows states to offer select home and community-based attendance services and supports. Kind of related to this, we are in our W work group exploring opportunities to provide training under a new Senate bill that was recently passed for specific folks, and one of which is including like home health related care that's being provided and ensuring that they are trained. And so we'll definitely have to explore this in that area of our work, because I think it would be a good complement to the work that we are doing.
We also have a partner from HCPF, the Colorado Center for Healthcare Policy and Financing, who is our state's Medicaid, that was just onboarded to our P work group. So I think it'll be a good conversation to have with her too. And it's also why I think is so helpful to have all these different partners in different areas of both state level work and community work to sit in our coalition, because there's so much work that that we're not aware of that can impact the work that we're doing. But thank you, Estelle, for that question.
There's a question from Mitsuo Tomita in the Q&A. I think this is about tracking and data collection, just tracking general caregivers, care partners. How is advanced care planning, financial planning, and end of life choices addressed? Is that collected anywhere by anybody in your coalition about end of life values, communication, support, anything that you can act on later?
We do education on advanced care planning, financial planning. Not sure about end of life choices, but those two are big pieces of education that we have in the professional education that we develop, including the e-learning module for primary care. Bring a good point with end of life choices. I don't think that is explicitly part of the education we provide. We focus on like risk reduction, early detection and diagnosis, and kind of like those early stages of the work, at least in the phases that we're in of our work now. I don't know of data sources that are collecting regarding any end of life values or choices, but that might be something to look out for. And one of the things that we did make sure to prioritize in our state plan when we developed the activities is that we knew that there were going to be a lot of different gaps in data, and we wanted to look to fill those with qualitative data. And so certainly collecting that type of data is something that we're looking into.
We have just a couple of minutes left, and if I may, if nobody else has a really pressing question, I would like to ask you. It was early on, as you were speaking, regarding the e-domain, education, engagement. What adaptations have you made to tailor your, whether it's community outreach strategy or communication tools or materials for some of your priority populations? What was the process you followed? What were the outcomes? How did you engage your partners in that?
Yeah, so there is a lot there. First, when we very first put together the advisory committee that informed the development of the state plan, we ensured that we reached out to different organizations or individuals that were community leaders representing priority populations. It was very challenging, and we had to get creative around the partner types that we engaged. As part of this, we also ensure that we provide compensation to every member that is in our advisory committee and our coalition, because we believe in people being paid for the time and insight that they have, even if it's, especially if it's lived experiences. So we do have that representation and that input that is able to help inform our work that has been there from the beginning. We also did a series of community engagement sessions early on in our work, which we co-facilitated and had led by community leaders of each of the priority populations rather than us being the leaders of that work. And we learned a lot from there around how these different communities wanted to receive the information. This, along with key informant interviews and conversations with members of our ADRDAC, helped inform these sections that you'll see throughout our plan called assurances for priority populations, that we are able to leverage as we continue implementing the work that we have in Colorado. Also, for the public awareness campaign, the first phase that we did this year, in a prior year of our work, so the year before, we had a communications firm focus on research within each of these communities to see how the messaging and materials needed to be tailored to reach those communities. One of the challenges that we have, it has been with engaging the American Indian Alaska Native community. So that's something that we're hoping to focus on a little bit more in this coming year.
Thank you. You sure have done a lot of work. Again, thanks to the robust engagement you really have with partners everywhere and serving those priority populations, right? It's so important. And I totally kudos to you for recognizing the importance for making the people with lived experience, first of all, engaging them, practically reaching out, and also compensating for their time. It's really recognizing the value of their voice and the time that it takes to participate, to contribute in busy lives that they sure have. So great. Wonderful. Great feedback for you to hear in our chat. Many of us in the field have reviewed Colorado state plan, ADRD state plan. It's one of the, it's a great document. Thank you very much for being here today, Monica and Joanna. It's been our pleasure to host you. Thank you for sharing so generously and answering all the questions. You might get more questions, actually, people reaching out to you. We will let you know if we receive any. Thanks again, and we will see you soon.
Thanks.
Thank you, everybody, for being here today as well.
Thank you.